Voice audible இருக்கா ரகு?
Yes, okay. The next session of the rapid revision series in pediatrics by Dr. And today we have the topic like anthropometry, developmental history, and other important make use of it. So thank you, sir, for joining us again today. So you can now start the session, sir.
Thank you, Raghu. Good evening, my dear students. Today is a very important topic actually. That's why it's called abbreviated as MAIN. M stands for milestone, A stands for anthropometry, I stands for immunization, and N for nutrition. So that's a main topic in pediatrics, and this is what differentiates the regular adult history taking from the pediatrics. So these four important components. So today we will be dealing on this, and we have tried our best to make it as brief as possible so that we will finish it by 6 o'clock in an hours period. We will try. So developmental history for 15-20 minutes, followed by Dr. Dietary ma'am. She is with us. Good evening, ma'am. She will be talking about the nutrition and immunization, followed by Ramya ma'am. She will be talking about the anthropometry. Okay. So let's go on with the topic. I will be talking on developmental history. So before going to that, just a brief overview of this. We are doing the pediatrics rapid revision from next weekend, 16th January. It will be all university exam oriented classes. So 6 online classes we are planning. So we'll be covering the important cases: cerebral palsy, newborn, abdomen, respiratory system, rheumatic heart disease, congenital heart disease, renal, nephrotic and nephritic, SAM, diarrhea, plus spotters. So you can register yourself at www.tinyurl.com/PEDS revision. It's a PEDS PEDS revision, REVISION. So if you have any doubts, you can WhatsApp me at this number 8220239296. Okay, so let's move on to the topic straight away. So development, what is expected of you in presenting a case relevant to the development with regards to the developmental history? Okay, so there will be two important common. One is a important case like cerebral palsy, where a detailed developmental history is important. They will expect in detail about the developmental history, because cerebral palsy is all about development, and you might even have to present it in the presenting complaints, because the mother comes with complaints of developmental complaints. So you may have to present it at the development as the presenting complaints itself. Okay, the other cases, at least basic milestones you have to elaborate. You need not be so elaborate as in cerebral palsy, but basic milestones you have to elaborate in any type of case scenario. So, and always it's safe to elaborate your history, especially in cerebral palsy, in a detailed, orderly manner. So you have to present it in an orderly manner. Do it in the 4 domains: gross motor, fine motor, social, and language milestone. And at the end, make sure that the hearing and vision are normal, because they are the windows of development. I always say, if hearing is poor, language is going to get poor. And finally, the interpretation is important. The no point in telling head control came at this time, the neck, and the child was having social smile at this time. It's irrelevant unless you give your interpretation. Finally, your interpretation will be, is there a developmental delay? So that is a very important question which you need to answer after all the history taking. Is there a developmental delay? If there is a developmental delay, is it global developmental delay or developmental dissociation? Global developmental delay in the sense that are all the 4 domains involved, then that is global developmental delay. Developmental dissociation, sometimes you can have a single domain being more affected. For example, in cerebral palsy, often the motor system will be more affected. Then is there a developmental dissociation, or is it a global developmental delay involving all the 4 domains? Is there a developmental regression? Okay, regression means whatever the milestones has attained, is it regressing? Then it is developmental regression. Whatever the achieved milestones, they start losing, which is not characteristic of cerebral palsy. Okay, it's a, you don't lose milestones. It is very characteristic of neurodegenerative disorders. So is there any developmental regression? Okay, and for older children, say 8 years old, the mother may not remember exactly when the head control. You cannot ask the mother when did head control come for an 8-year-old child. Mother may not say that it came at 4 years, 4 months, 5 months. She may not be very clear at what age exactly it came. So the best option would be for an older child is compare with someone else, compare with the siblings. So she might clearly say that comparing with my other kids, the development was regressed, the development was delayed, something, or it was on par with the other siblings. So compare with the siblings, and the scholastic performance is a good marker of the development. Okay, how the child is performing in the school. So that is a very important marker which you can present. And some principles are: development is cephalocaudal, which means it starts from the head, that is head control, and it goes to the trunk, so roll over, then the hips, so sitting, then the legs, the walking. So it is cephalocaudal in progression, the development. There is a specific order. You don't have a child walking first, followed by sitting. Okay, first is sitting, then only walking. So that is the order, and the order never changes. There may be delay, but there will be no order and change in the development. Similarly, you should also present in the same order. Do not present in a haphazard manner. And another important point to remember is primitive reflexes have to be lost in certain scenarios. They will ask you, okay, certain reflexes have to be lost, then only the development will come, such development. For example, for the unidextrous and bidextrous grasp, the grasp reflex has to disappear. Similarly, for rollover, the asymmetric tonic neck reflex has to disappear. Okay, and for preterm babies, development may look a bit delayed because we should always correct the age for the development. For example, the baby is born 2 months ahead, then you have to correct the age and then calculate the developmental age. Because for a 1-year-old preterm who was born 2 months ahead means the exact actual corrected age is 10 months. It's not 12 months. Okay, so you have to correct the development, correct the age, and then interpret the development. Okay, and you need to understand what is developmental surveillance and developmental screening. In a OP basis clinic, a pediatrician just like enquires what is happening to the milestones, and whatever the history you are taking, it is developmental surveillance. And developmental screening is a proper validated tests which you apply and give a score, which means an objective way of assessing. It's called developmental screening. You have a lot of Trivandrum development screening test, Baroda developmental screening test, like that. Okay. Coming to the overview of the milestones, it's very important. It may be a bit difficult to remember everything. You keep on hearing again and again, you will remember this. So we have tried to pack all the milestones as concise as possible. So first domain will be gross motor milestones. First important milestone is head control. At 4 months, you get head control. Rollover. So I said already, it comes at 5 months. The asymmetric tonic neck reflex has to disappear. Rollover comes at 5 months. Then sits with support at 6 months, sits without support at 8 months. Then the child crawls, crawling at 9 months. Then the child creeps, creeping at 10 months. So what is crawling? Crawling is abdomen touching the floor. And creeping is walking like a bear, almost like abdomen will not be touching the floor. So crawling 9 months and creeping 10 months. So remember, A comes before E. So crawling 9 months, creeping 10 months. Okay. Then stands without support at 1 year, and walks at 15 months and runs at 18 months, and climbs upstairs one step at a time, which means keeps both the feet on each step and then moves. So that is climbs upstairs one step at a time, kicks a ball by 2 years. Similarly, for 3 years, it is climbs upstairs with one alternating feet for each step. Okay, it's a bit better than the 2 years. Okay, so and 3 years, remember, riding a tricycle. So climbing upstairs, both the feet on each step will be 2 years, with alternating feet on each step will be for at 3 years, and riding a tricycle is 3 years. Okay, and riding downstairs, now coming downstairs in the steps uh, with alternate feet, it comes at 4 years, hops at 4 years, skips at 5 years. Okay, so okay, so just a revision: head control at 4 months, sitting with support 6 months, crawling at 9 months, creeping and cruising at 10 months, stands without support 12 months, walks 15 months, runs at 18 months, climbs upstairs with 2 steps is 2 years, and a tricycle 3 years, and downstairs it's 4 years, and skips by 4 years, skips by 5 years. Okay, okay. Okay, now coming to the fine motor milestones. For fine motor milestones, the grasp reflex has to disappear. So the hand will be open only by 3 months. Okay, then you have bidextrous grasp and mouthing by 4 months, which means both the hands are utilized for grasping. So that is 4 months. And unidextrous grasp and transfer of object from one hand to the other hand by 6 months. Then the most important milestone, if they ask you in fine motor, is pincer grasp, which is holding object with your thumb and your index finger. So that comes at 9 months. Very important milestone. Usually it is not achieved in cerebral palsy. Okay. Then mature pincer grasp by 1 year, and casting, which is releasing of objects on request, happens at 1 year. And child starts independently drinking with a cup with some help. With some help is 15 months, and starts feeding with cup. Feeding with cup is at 18 months. Remember, handedness comes at 18 months. If the child gets handedness before that, assume that the other part of the limb is a bit weak. And the child starts scribbling at 1.5 years, turns pages 2 to 3 pages at a time and starts scribbling. Okay, and makes a tower of 3 cubes by 1.5 years. Okay, 3 cubes by 1.5 years. Okay, and then child starts turning pages 1 at a time. Okay, child starts pages 1 at a time and makes horizontal and vertical strokes at 2 years. And remember this formula: multiply by 3 for making a tower of cubes. For 2 years it is 2 into 3, 6 cubes, and for 3 years it is 3 into 3, 9 cubes. Okay, so tower of 9 cubes is by 3 years, and they start dressing and undressing with some help at 3 years. And remember, drawing a square at 4 years, it's easier to draw a rectangle, so rectangle by 3 years. And draw a man with 3 parts at 3 years, and draw a man with 4 parts at 4 years. Drawing a square at 4 years copies a square cross at 4 years. Okay, so and at 5 years they will be able to draw a triangle. So remember, drawing a square is easier than drawing a triangle. It has an angle, so at 5 years you draw a triangle. Similarly, draw a man, the neck, it's very fine. Okay, so by 5 years they will be able to draw a man with head, neck and limbs by 5 years. So most important summary will be hands will be open by 3 months. Then you have the bidextrous grasp by 4 months. And then the unidextrous grasp, with one hand they have the object, and then they start transferring object from one hand to the other at 6 months. Most important milestone will be pincer grasp at 9 months. Okay, and self-feeding with cup 15 months, feeding self with help is 15 months, without help will be 18 months, handedness 18 months, and then scribbling by 18 months, and then vertical strokes by 2 years, and the tower of 2 into 3 cubes, which is 6 cubes at 2 years, tower of 3 into 3, 9 cubes by 3 years, and draw a rectangle by 3 years, draw a square by 4 years. Okay, and next milestone is a social milestone. Okay, so it is a most important milestone will be social smile. At 2 months you get the social smile. Okay, and 2 months you get the social smile. 3 months you have the recognition of the mother, and 4 months you have the hand regard. So they start intently looking at the hands and laughing out loud, enjoying the mirror image by 6 months. And just as they enjoy their own image, they will also have stranger anxiety by 6 months. Okay, and enjoys peekaboo and waves bye bye by 9 months. So by 9 months, they will have waving the bye bye and enjoys the peekaboo game. And they start playing peekaboo game by 12 months. Okay, and mimicry starts appearing from 15 months, and mimicking the action of others by 18 months. And they will be dry by day by 18 months. Okay, and 4 parts of the body. So they start pointing to 4 parts of the body by 2 years, and they start listening to stories by 2 years. Okay, and dry by night by 3 years. So dry by day by 1.5 years, and usually dry by night by 3 years. And there is a specific play called parallel play, where they play with other children. They don't interact with them, but they are happy to be beside them. So parallel play by 3 years. And they do wash their face, brushes their teeth, and may use toilet by self, and group play. So it's like independent. So they are independent, they're ready for going to the school. So by 4 years. Okay, and finally they dress unassisted and domestic role play by 5 years. Okay, so they do some role play, helping out the mother by 5 years. Okay, and final milestone is the language milestone. Okay, for this, hearing should be very important. So it's simple to remember: 3 months cooing, 6 months monosyllables, ma, ba. So that will be your monosyllable. 6 months monosyllables. Mama, baba will be your bisyllables. So 9 months bisyllables, and 2 words by 1 year. You get your 2 words. Okay, then jargon, a bit not understandable by 15 months. So they start using the jargon. Okay, so that is by 15 months. And by 18 months they have some 10 words by 18 months. And by 2 years they will talk a simple sentence. So 3 words simple sentence by 2 years. And by 2.5 years they will be able to identify themselves as I. They will be able to tell their name by 2.5 years. And a complex sentence, 6-worded sentence by 3 years. And you have 250 word vocabulary, and they know their age and sex by 3 years. And then they tell a story by 4 years, and know 3 colors by 4 years. Okay, and simple addition, count up to 10, all the max related things comes by 5 years. Okay, so after knowing these developmental milestones, you have to give your interpretation. Okay, it doesn't stop with knowing the milestones. They will ask you the questions about milestones, but you have to give your interpretation. For example, a 3-year-old male child presenting with complaints of not able to sit, stand till date, not speaking words till date, not able to eat on his own till date. So this will be your presenting complaint. So you have to elaborate it. Okay, so you have to elaborate the gross motor, you have to elaborate the fine motor. Okay, you have to elaborate the language. Okay, and you have to say for like this: neck control attained at 8 months instead of the 4 months. Rollover attained at 1 year instead of the 5 months. Sitting with support 2 years instead of the 6 months. And at present, 3-year-old, he is not able to sit or stand or walk independently. His gross motor age is 6 months. So you have to identify what is his gross motor age. Similarly, you have to talk about the fine motor. Finally, say his fine motor age is 6 months. Just like that. Social, finally, you talk his social age is around 2 years. And language, also in the similar panel. His language developmental age is 1.5 years. So you have to tell us what is the gross motor age, what is the fine motor age, what is the social age, what is the language developmental age. Okay. And finally, you give a summary of the development. So 3-year-old child, say whether all the 4 domains are involved. So it's a global developmental delay. And with whether anything is more pronounced, with motor delay more pronounced. So here motor delay is more pronounced, and the gross motor age is 6 months, fine motor age is 6 months, social age is 2 years, and the language is around 1.5 years. And there is no developmental regression. His hearing and vision are normal. So like this interpretation, if you give, you are really on track with a good presentation. And finally, they will be expecting you, if you are presenting really well, what is the developmental quotient. So general developmental quotient is the average of all the domain developmental age. So you add all the developmental age. So 0.5 plus 0.5 plus 2 years for social and 1.5 for language, and divide by 4 and multiply it by 100. So it comes, here it comes to around 33% as the developmental quotient. So anything less than 85% is considered abnormal. So you can give the general development quotient, but suppose if one domain is very much affected than the others, then you can give specific domain development quotient also. So gross motor developmental quotient is this much. Okay, social developmental quotient is this much. So whatever age, the developmental age, divided by what is the chronological age and multiply it by 100 and give the developmental quotient. Okay, so remember, before I stop, important milestones which you should know is head control 4 months. Don't forget that. If you forget this 4 milestones, which means you don't know development. Okay, so head control 4 months, pincer grasp where the thumb and the index finger comes 9 months, social smile 2 months, and simple sentence by 2 years. Okay, I hand over to Gayatri ma'am for the next topic.
Thank you, sir.
Thank you, ma'am. Thank you, ma'am.
Yes. So now we'll go for diet and
You can share, ma'am.
yes. So good evening all. This is Dr. Gayatri speaking about the diet and immunization. So first we'll finish off the diet part. So it may be vague, but still it's very important for the pediatrics. So these are the preliminary basic history that we have to deal with. If it is less than 6 months, so we'll be dealing only whether the child is breastfed or if it is a formula fed. So if it is a breastfed, we have to see whether the breastfeeding is adequate or not. So this can be achieved by wetness test. What is wetness test? If the child is breastfed and if the child is passing urine for at least 6 to 8 times per day, then the child is having adequate breastfeeding. So the need for the top feed is not required. So this will actually decrease the anxiety of the mother as such. When if the mother doubts that whether the child is not getting not an adequate breastfeeding, then we can examine these things so that we will get to know um, what is the breastfeeding status or the whether adequacy of the breastfeeding is there or not. If it is inadequate, then the child weight gain or the weight remains static, and this history will point out to you. That is, the child cries soon after the feeding and falls sick very often. Now coming to the infancy. Infancy again, this is mainly the breastfeeding plus the top feeding. So this is complementary feeding, not the top feeding. This is the complementary feeding. So when was the child started with complementary feeding? That is, the timing has to be noted, whether it's like 6 months or earlier than that. Okay. And in case of complementary feeding, what is the consistency they are using? That should be thick enough that it shouldn't fall off the spoon. If they're making it a very diluted form, that's going to cause a malnutrition for the child. So the consistency of the complementary feeding should be noted. What is the type of food? Whether it's a rice based or vegetable based or very fruity based or something like that. So if it is a rice based and some amount of vegetable, everything was combined, then they will have a complex food pyramid is reached by the child. And what is the quantity the child is taking, and what is the timing, how many times per day the child is taking the complementary feeding, and whether the breastfeeding is continued or not has to be inquired. When it is more than 1 year, it's always a 24-hour recall method. That is, a child who was having a full diet at the time of normal time of the illness, not during the illness, just before the illness, what was the diet the child had. Say, for example, if the child is having fever for 2 days or so, so before that, what was the 24-hour diet, what the child was taking, has to be taken in a detailed manner. Okay. And if there is a milk intake apart from the breast milk, that has to be taken, and the quantity of the milk has to be taken too. And if in case of junk foods or the packaged food, that has to be mentioned separately also. So we'll be dealing in detail of the 24-hour recall method. So first we'll see what is calorie calculation, basic about the dietary history. So calculate the for the expected weight. The most important thing is that you have to calculate the calorie of the child for the expected weight. Say for example, if the child is 2 years and the weight of the child is just 7 kg, whereas the expected for the 2 years will be around 13 to 14 kg. If you are calculating the calorie intake for 7 years, 7 kg, it will be considerably low. So in that case, we have to calculate it for the expected weight only. That is for the 13 kg. So we have two methods for the calorie calculation. First method is with the age, that is 1000 kilocalorie for up to 1 year, and next add 100 kilocalorie per year for up to 12 years of age. For example, if an energy requirement of a 4 year is, I am calculating for a 4-year-old child. So it will be 1000 kilocalorie plus 1000 into 3. That is already 1 year is over, and for the remaining 3 years, we are multiplying with the 100, and which will give you 1300 kilocalorie. Another method is the easy method, that is the Holiday-Segar formula, for which the child weight is, if it is 10 kg, then the calorie requirement will be 100 kilocalorie per kg. If it is between 10 to 20 kg, it is 1000 plus 50 kilocalorie per kg for every increase in weight from 10 kg. Okay. So if it is more than 20 kg, it is like anyways, if it is more than 20 kg, it is like 1500 kilocalorie plus 20 kilocalorie per kg for every increase in more than 20 kg. So this is how we calculate the calorie. So this is the expected calorie we are calculating with this. Now coming to the protein requirement. So easy method which you can remember well is this. Just remember from 2 to 1. So we will be having some fractions in this. So it is like 0 to 6 months. The protein requirement is 2 to 2.0 gram per kg per day. If it is 6 months to 1 year, it is 1.5 to 2 gram per kg per day. If it is 2 years to 12 years, it is 1.5 to 1.2 gram per kg per day, and it's more than 12 years, it's 1 gram per kg per day. Maybe around the puberty, it may increase, but still, for all practical purpose, you just follow only these 4. So this is a big list, but it's very easy to remember. I'll make it very easy. So what is that? If we have to calculate the calorie, what is the food intake of the child, and what is the calorie of the food that the child is taking to be known. So the most commonly what we eat is like rice, wheat, dal. So all these in 100 gram, everything will be kilocalorie will be 340 kilocalorie. So for the rice, the protein will be 8, and for the wheat, the protein will be 10, and for the dal, which is the most higher, and the protein will be 24. Breast milk, for every 100 ml, the kilocalorie will be 70, and for the protein, it is 1.3 kilocalorie per 100 ml. So in case of cow's milk, which will be a one medium cup, which will correspond to 200 ml, the kilocalorie will be 130 kilocalorie, and the protein will be 6. In case of high fat milk, the kilocalorie, for protein for the high fat milk, even for the 100 ml, it is 6. So in that case, you have to switch over to 12. Okay. Next is sugar. Sugar, 1 teaspoon will have a kilocalorie of 20, whereas it has got no protein. And next is any fatty item, that is ghee, butter, or oil. So the 1 teaspoon of any of this is going to produce a kilocalorie of 45 gram and protein of nil. So now coming to the practical thing. So 1 katori or 1 serving of dal, that is 25 gram, is going to produce a 85. So here we saw everything as 340, 340, 340, and here we are going to make it as a fraction. So this will be the 1 serving. So if the child is taking a 2 katori or 550 gram, they are mentioning it has to be multiplied in that way. So for the dal, it is 1 katori, it is 85 kilocalorie, and the protein will be 6. 1 bread or roti, which is corresponding to 25 gram of wheat. Okay, so with this will be again 85, and the protein will be 2.5. 1 cup of rice, 1 katori cup of rice, which will be around 225 gram, which will be again kilocalorie will be 85 kilocalorie, and protein will be 2. And ragi and upma, they are going to have the same kilocalorie and the same protein. So it's very easy. Again, it's the 85 kilocalorie and for both of the things, and the protein will be 3. 1 cup of vegetable, be it any vegetable or mixed vegetable, we cannot remember for each and every vegetable separately. So make it as a whole figure. So 1 cup of vegetable, that will be 1 serving, that is again 25 gram, which will be 85 kilocalorie, and the protein will be again 2. In case of nuts, if it's 100 gram, nobody will take 100 gram nuts. So if in case of 100 gram, it is again kilocalorie will be 550 and the protein will be 20. In case of banana, 1 medium-sized banana, the kilocalorie will be 110 and the protein will be 2. 1 boiled potato, which is again a medium-sized, it will correspond to 40 kilocalorie and the protein will be 0.5. Next, in case of infancy and around the toddlerhood, we will be having the Cerelac, which is again 3 scoops, which correspond to 25 gram. This kilocalorie will be 100. So here we will be seeing all 100 kilocalorie. So 100 kilocalorie of Cerelac, which will produce a protein of 3.5. 2 idlis will give you a kilocalorie of 100 and the protein of 4. 1 dosa will give you a kilocalorie of 100 and the protein of 3. So side dish for all these things. So maybe a coconut chutney. If it is a sambar, you can take that dal. Okay. So it's again a 80 kilocalorie and the protein of 1. Egg, very important. You're not committed to forget it. So egg, the kilocalorie will be 80. 1 egg will produce a kilocalorie of 80 and then protein of 6. Be it a case of biscuit, a normal biscuit, not a creamy one. So normal biscuit may be a Mary or something like that. So biscuit, if it's a 4 in number, it produces a 80 kilocalorie. So producing a protein of 2. So now we know the kilocalorie of each one. So we are going to calculate a 10-year-old boy with a boy with a weight of 22 kg. So we are getting a 24-hour recall method from the parents. So this is the table column that we'll be producing. So we'll be having a 5 columns which will produce a time and what is the food and the quantity the child is taking and the calorie and then protein. So say for example, if the child is taking in the morning, it's idli with chutney. So idli, if the child is taking a 3 quantity, then already I said that 2 idli will produce you a 100 kilocalorie. So 3 is going to produce a 150 and the protein is 6. Oil, any fat item. So 1 teaspoon, it's going to produce a kilocalorie of 45. So be it oil or be it butter or ghee, anything. Chutney, 1 tablespoon is going to produce you a 80 kilocalorie and the protein of 1. In the mid morning, the child is taking a snack of banana and it's 1. and its kilocalorie is 110 kilocalorie and then 1.5. Lunch, it's again a rice, sambar or dal, whatever it's there, and then along with the vegetable. So rice, the child is taking 2 cup or the 50 gram. So it's the kilocalorie will be 170 and the protein will be 4. Dal, it's half cup and which is producing a kilocalorie of 45 and protein of 3. Vegetable, it's again a half cup, again it's producing a kilocalorie of 40 and then protein of 1. At the evening snack, the child is taking a egg, which is 1 in number, and the kilocalorie will be 80, and then protein will be 6. Dinner, for the dinner, the child is taking roti with dal. So roti, the child is taking 2 rotis, and the kilocalorie will be 85 plus 85, 170, and then protein is 5. Dal, half cup, again 85 half is again approximately 45, and then protein is 3. Ghee, any oil item, 45 will be your fixed thing. So 1 teaspoon of ghee is going to produce a 45 kilocalorie. So post dinner, the child is taking a diluted milk, of which 100 ml is the milk, and then 50 ml the child is taking a water. So among this, the 100 ml we are taking as a quantity, and then kilocalorie will be 75 kilocalorie, and then 3 will be the protein. Along with the milk, the child is also taking a sugar, which is 1 teaspoon, which is corresponding to 20 kilocalorie. So, with this, we know what the child is taking and the calorie. So, this is again a rough method. We can just have some amount of front and back. That's not an issue. Okay. So, this calorie, if you are totaling up together, you will be getting what is called what is called the calorie intake that actually the child is getting, and this will be your protein intake. So let's see what is that. So the calorie intake of this child is 1120 kilocalorie per day, and the protein intake is 33.5 gram per day. So now our main objective is to calculate what is the expected calorie and then what is the expected protein. So for the expected calorie, we need to know the expected weight of the child. For a 10-year-old child, the expected weight will be given by this formula. That is for 7 to 12 years, we will be having this formula, that is 7x minus 5, where x is the age in years. So 7x minus 5 divided by 2. So when I'm substituting this, I'm getting the weight as 33 kg, whereas the child age weight is 22 kg only. So by first method, as I already explained, for the expected calorie will be 1000 plus 100 into 9, which is around 1900. For the second method or the holiday Sega formula, I'm using this 1000 for the after 10 to 20, I'm taking as 50 kilocalorie per increase in weight, which is around 500, and then after 20, we are having this as our 20 kilocalorie per kg increase. So that will cost around 280. So completely the 1780 kilocalorie. So either of that, I'm taking the lower one, so that I'm calculating what is the expected protein and what is the calorie deficit and the protein deficit of this child. And we missed to do this, and it's a expected protein. So expected protein of this child will be 1.4. I'm taking around that. So so till 12 years, we'll be having like 1.2 to 1.4, 1.5. So averagely, I'm taking as 1.4 into 33 kg of the child. So into 33, which is around 46.2 gram per deciliter. So the calorie deficit in this case is 1780 that we got from the formula, and the intake what the child is taking is 1120, which will be 660 kilocalorie per deciliter. And the protein deficit is we got as 46.2 and then minus 33.5 what the child is taking, which is around 13 gram per deciliter. So with this, we have to give the balance of food with the deficit. So this is the way we will be finishing off. So now we'll move on to immunization part. In the immunization, first thing we have to remember is that national immunization schedule. Next, what are the live vaccines? What are the killed vaccines? What is the timing, it has to be administered a basic adverse effect of each vaccine, and then in case of loss to the follow-up or not given any vaccination, what and child coming to at later age, what is the catch-up age that you will be providing? So I'm just giving a glimpse of all these things. Okay. So before going on to the immunization schedule, so we need to know what is the basic concept behind the vaccines. So first we'll go for the live vaccine. So live vaccine, whenever it's injected, it gives a multifocal lymph node activation. So even a single dose can produce a high antigenicity. So, but sometimes what happens is that primary vaccine failure can happen. So we may require second dose for it. So usually live vaccines like BCG, they are given at single dose, or sometimes a second dose can be given like MR vaccine. Okay. Most of the live vaccines, they are given in subcutaneous and the intradermal because these are taken away by the dendritic cells. So these are get activated and produced to the antigen presenting cells. So where the dendritic cells are present more in the skin, so subcutaneous and the intradermal option is going to produce a good coverage for the vaccine. Another important thing, basic thing about the live vaccine is that it has got a immunological interference. So it has to be, if in case if you're giving a live vaccine like 1, 2, 3 together, it's okay. It has to be given within 24 hours, or you cannot give like I'm giving a one vaccine today and another live vaccine after a week. So between two live vaccine, you need to have a 4 weeks of difference. Gap should be there. Or in certain circumstances where you have to administer for betterment of the patient, then it has to be given in a different route. For example, if the first live vaccine was given in a subcut, then it has to be second to be given in an intradermal or any other route. Okay. And any contraindication for the vaccine will be anaphylaxis. So any vaccine, be it alive or killed, anaphylaxis is an absolute contraindication for the live vaccine. For particularly for the live vaccine, it is contraindicated in the case of immunosuppression, like HIV, but in a case of symptomatic, and sometimes a few of the live vaccine can also be given depending upon the CD4 count of the child. On high dose of the steroids. For example, in a child with a nephrotic syndrome, on the steroid is on 2 milligram per kg, then we cannot give this. When it's coming to the alternative dose, or when the child was tapered off the steroid and 4 weeks gap to be given, and then it was live vaccine can be given. Next, in case of pregnancy, it is again contraindicated. Moving on to killed vaccine. When the killed vaccines are injected, it is going to produce a local or unilateral lymph node activation. So it requires multiple injections to be given. Most of the time, the killed vaccine will require adjuvant to improve the immune response. So these adjuvant, what happens when it's given subcutaneous, it is potential to cause an abscess. So most of the time, most of the killed vaccine, the route of administration is IM, as in the case of DPT. So for any vaccine, as well as for the killed vaccine, between 2 doses, at least 4 weeks of difference should be there, because the primary antigenicity to be increased, and then next can be given. Time for the booster should be at least 4 months of the last dose. So minimum of 4 months to be there. For any adverse effect, that is the anaphylaxis, this is again an important question in your viva or whatever it's. If I give a vaccine and the child went for anaphylaxis, what will you do? So you have to give a adrenaline. So adrenaline dose to be known, that is 1:1000 concentration. It is 0.01 ml per kg, IM or IV. No subcutaneous to be given. Can be repeated 2 to 3 times at least 5 to 10 minutes apart. Now moving on to vaccine vial monitoring. So this is again an important question, which we'll see in the case of OPV, all those things. So vaccine vial monitoring, it is actually the viability of the vaccine is monitored in this case, not the temperature sensitivity. Okay. So we have this inner square which is transparent, or the which is white in color, and the outer circle which is purple in color. So if this color actually matches with that of the square, If the outer color is matching or more than that of the outer circle, then we should not use it. Rest of the time you can use it, provided the expiry date of the vaccine is there. Let's move on to the national immunization schedule. So this is, you have to commit to memory, no other way. So at birth, we'll be giving this BCG, hepatitis B, and then OPV birth dose. So BCG, it has to be given at birth or as early as possible till 1 year of age. So if a child of 7 months coming to you at first with no vaccination, then you start with the BCG and carry on other vaccination. So at birth, it is 0.1 after 1 month it is 0.1 ml, and before 1 month it is 0.05 ml. That has to be given intradermally in the left upper arm. Hepatitis B, it has to be given at birth or as early as possible within 24 hours. It is 0.5 ml IM. Okay, in the anterolateral aspect of the or mid thigh. OPV, it's again a birth dose. It is orally given. It should be given as early as possible or within first 15 days. So 2 drops, and orally it has to be given. Next, we have the 16-14 vaccines. That is the OPV, pentavalent, and rotavirus vaccine. So, rotavirus is again in a pilot project. In many of the states, it was not accepted. In states like Haryana, Tamil Nadu, they are all giving this rotavirus vaccine. So, this is the national immunization schedule where we are giving 6, 10, 14, where the OPV is given as oral drops. Pentavalent is DPT, diphtheria, pertussis, tetanus, toxoid, and then Haemophilus influenza, and then hepatitis B. So pentavalent is given as 6, 10, 14 here, and then pentavalent is given as IM injection, OPV oral drops, and then rotavirus, it's again a 5 drops orally. Okay. IPV, actually we are replacing the IPV, we are replacing the OPV with the IPV. So it is given at 14 weeks. This is an inactivated polio virus, so we are giving it as IM. Now coming to the 9th month dose, which will cover measles first dose and then vitamin A first dose. So measles first dose is 9 months. It can be given from 9 months to 12 years. So mostly we can give up to 5 years. If the child has missed a vaccine, so we can give at any time till 5 years. So it is 0.5 ml separate because this is a live vaccine. Vitamin A, it's oral dose that is given at 9 months of age along with the measles vaccine. So it is 1 ml, 1 lakh international unit at 9 months of age. Next, we are getting on to the older age group, that is the 16 to 24 months, where we are giving DPT booster, measles booster or measles second dose or the booster, and then OPV booster. So measles is a subject vaccine, DPT again a IM, the anterolateral aspect of the mid-thigh, and then OPV is a oral dose. Second dose of vitamin A to be given at around 16 months along with these. So this will be 2 ml, that is 2 lakh international unit, it's oral. Next, second DPT booster will be around 5 to 6 years, which is again an IM injection, and then from 10 years onwards, it will be TT injection, which is again an IM injection. So this is lastly we saw the national immunization schedule. Now we are getting on to the IAP immunization schedule. So in this case, what is the difference is that birth vaccine is the same. In case of 16-14, apart from the Penta OPV, we are giving this IPV also, first, second, and third dose, and OPV is being replaced with IPV actually in case of IAP schedule. And then we are giving this pneumococcal vaccine, and then rotavirus. That's it. Pneumococcal is 1. First dose is 6, 10, 14. 6, 10, 14. Okay. First, second, and third dose. At around 6 and 7 months, we are giving this influenza first and second dose, which is around 0.5 ml IM. Next is 6 to 9 months, we are giving this typhoid conjugate vaccine. This typhoid conjugate vaccine, nowadays it said that no booster dose is required. So one time, 1 TCV is given, it's enough for the life. And next is we have this around 12 months, that is hepatitis A vaccine. In the case of live attenuated vaccine, it's the single dose, whereas in the case of killed vaccine, it is 2 doses. So it will be apart, 6 months apart. So 12 months and then 18 months we are giving this hepatitis A second dose for the only killed vaccine. If the child is given a killed vaccine at first dose, then it has to be given killed vaccine at second dose, which is around 18 months. Okay. Next is varicella vaccine. Varicella first dose is given at around 15 months and then repeat dose is given at around 18 months. Okay. This is a live vaccine, so it can be given a substitute. And finally is the these are all the same thing, and MMR booster can be given at 4 to 6 years, unlike national immunization schedule. And then around 10 to 12 years, we are using this Tdap, unlike the national immunization schedule, where we are using this TT. So Tdap has to be given, and then human papillomavirus can be given. So actually, this is mainly for the adverse effect. So DPT, it's very important. What is the contraindication and what is the adverse effect? So usual adverse effect will be local pain, swelling, and then fever. So contraindication, that's an absolute contraindication. You should never repeat the dose of the DPT. So this include progressive neurological disease, anaphylaxis after previous dose, or encephalopathy within 7 days of a last dose. So this is an absolute contraindication. You should never repeat the dose. This is now we are going to see the what is the precaution. So in this case, we can administer the vaccine, but we cannot. We can administer the vaccine, but we have to keep it as a caution. So we have to keep on observing the child for some certain period of time. So in this case, the previous dose associated with fever more than 40.5 degrees Celsius within 48 hours, or collapse within 48 hours, persistent inconsolable cry for more than 3 hours within 48 hours, or any seizure episode within 72 hours. These are the newer vaccines. So I'm just giving a glimpse of these. So rotavirus vaccine, we have this monovalent and the pentavalent. So monovalent will be given as 1 ml or 1.5 ml liquid, or penta will be given as 2 ml. So in the case of IAP schedule, monovalent is 2 doses, and whereas the pentavalent is 3 doses. So what we are giving in national IAP schedule is RV5, so we are having a 3 doses. Otherwise, it's only 610 only. Okay. So very important complication to remember for the rotavirus vaccine is the intersusception. So this is an adverse reaction. So you have to remember that. Now coming on to the pneumococcal vaccine, this is given as 0.5 ml subcut or IM. So for the IAP schedule, as already mentioned, it is 6, 10, 14. We are giving this, and booster dose to be given at around 15 to 18 months. Okay, this child a catch-up can be given till 59 months. So any contraindication you can mention as anaphylaxis. So most commonly nowadays we are getting this adolescence vaccine, that is the HPV vaccine. So we have this 2 variant, that is divalent and the quadrivalent. So divalent is dose is 0, 1 and 6 months, and quadrivalent is 0, 2 and 6 months. Okay. So IAP states that girls of 11 to 12-year-old can be given. The catch-up can be before initiation of any sexual activity. So this dose or the route will be 0.5 ml IM upper arm, that is in the belfry. So whatever we take home is, for the diet, we have to make a 24-hour recall method, so that we'll be knowing the what is the calorie intake of the child, protein intake of the child. Once this was known, calorie and the protein, expected calorie and the protein of the protein to be taken for the child can be calculated for the expected weight, and then calorie deficit and the protein deficit to be done. So that deficit has to be given in your management, so that the additional food can be incorporated for the child. Next is for the immunization part, live vaccine. Remember, it's usually a single dose. Sometimes a second dose can be given. It's subcut or the intradermal route. For the killed vaccine, it requires a repeated injection. Mostly it is an intramuscular route. So any vaccine contraindicated in the case of anaphylaxis. So you can remember, for any contraindication, you can say is anaphylaxis to this vaccine, already experienced or something. So in that way, and specifically like rotavirus, it's an intersusception. BCG, it is a disseminated tuberculosis or suppurative disease, lymphadenitis, all these are. Like for measles, it is a toxic shock syndrome. So remember at least one point for each vaccine. And for the DTT, it's very important to remember the absolute contraindication and then. So thank you.
Thank you, ma'am. Thank you very much. It's like you're condensed into a small capsule within less than half an hour. Thank you very much, ma'am.
Thank you, sir.
And we move on to the next topic, very important topic on anthropometry. Dr. Ramya ma'am will take over. Ma'am, thank you. You can start, ma'am.
Yes, sir. Sir, my slides are visible, sir.
Yes, madam. Yes, madam.
So now we'll be discussing about anthropometry. In anthropometry, I'll tell the basic things like how to measure each parameters and few significant points which will be asked for the exams. So anthropometry, anthropo means it's human and metry means measure. So basically measurements in our various, we are measuring certain important things in our human body and each one has a significance. So what is the importance of doing this measurements? Why it is important? To assess the nutritional status and health status of the children and also to track trends and growth over time. So these are the two importance of measuring the weight, height, head circumference and chest circumference and various other parameters in children. So today we'll be discussing all those things: weight, length or height, head circumference, chest circumference, mid upper arm circumference, body mass index. So these are the very important things which we will measure for each children given for exam. So first we'll be discussing the weight. So what are the instruments used for weighing the child? One is digital weighing scale, which is the most commonly used, spring machine and beam scale. The spring machine is highly unreliable and doesn't give the accurate measurement. So beam scale and digital weighing scale are accurate and most commonly used is digital weighing scale. So how to measure in neonates? Neonates, they should be placed on the scale with all clothes and diapers. Both should be removed. And small children, children who cannot stand alone on the scale will be weighed with the assistance of an adult. First, the adult will stand on the scale and then press the tar button to show 0 and then will carry the child to record his weight. So first we will make the adult to stand and then we will press the 0 button. Then we will ask him to carry his child and then we will subtract the weight from his own weight. So this is how we measure for the very small children who cannot stand on their own. For older children, we should ask them to remove their shoes and then stand on the scale. So this is how we measure for 3 categories. So this is the beam scale. So you need not remember all the birth weight or all the weight of the different age groups. There are certain important things which you should remember. So the average birth weight of an Indian child is 3 kgs, if you remember in that way. So birth weight doubles by 4 months, it triples by 1 year and quadruples by 2 years. Just remember these 3 important points. It doubles by 4 months, triples by 1 year and quadruples by 2 years of age. So there is a which formula to calculate the age appropriate weight. You can, if you remember this formula, it is easy to calculate for any age given. So less than 1 year, it is weight in kgs. How to calculate the weight is 9 plus age in months. It is not years, whole divided by 2. So 1 to 6 years, it is 2 into age in years plus 8. Please remember less than 1 year, it is age in months. And 1 to 6 years, it is age in years. 6 to 12 years, it is 7x. Previously, Gayatri ma mentioned the same formula. So it is 7x minus 5 whole divided by 2, where x is age in years. So this formula, if you remember this formula, it is easy to calculate weight for any children. Next is length. So when do you call length? When the child is less than 2 years of age, you take the length of the child. When the child is more than 2 years of age, we usually mention it as height. We make the child stand and take the height. When the child is less than 2 years of age, we make them lie down and measure the length. So less than 2 years, why we make the child lie down is because of the excessive lumbar lordosis during this age. We make the child lie down to get the exact length of the child. And also less than 2 years, a child will not be able to stand properly in a stadiometer. So that is the reason why we take length less than 2 years of age. So this is called infantometer. So this is the instrument we use for measuring the length of a child. So there will be a fixed head piece, and this is a fixed head piece, and there will be a horizontal board and an adjustable foot piece. So the child, usually 2 persons are needed to check the length in using infantometer. So one should hold the child, the other should press the knee to make it straight, then and you should fix the foot end. So this is how you measure the child length of the child using an infantometer. Lay the child on the infantometer with feet towards the foot piece and the head against the fixed head piece. The head should be with the Frankfurt plane perpendicular to the floor. So this is called Frankfurt plane perpendicular to the floor. And I will show that one more picture also. Align the child's leg by placing one hand over the knees. So this hand should align the child's leg. With the other hand, slide the foot piece to rest firmly at the child's heel. The toes must point directly upward with both soles of the feet flexed perpendicular against the foot piece. This is very important. Measure by sitting down with the eyes at the level of the infantometer. So you will be needing 2 persons to measure the length. So standing height, it is used in children more than 2 years of age. So this is called stadiometer. This is the instrument we use to measure the height of a child who is more than 2 years of age. So this has a vertical board, backboard, and an adjustable headpiece. So this is a wall mounted one. So it also has a vertical backboard and an adjustable headpiece. So you should make the child stand. The most important thing is 3 things you should note: the heel, buttocks, shoulder blade, and the occipital prominence. This should touch the wall, and then only we can take the measurement of the child. We will get the exact measurement of the child. So this is called the Frankfurt plane. Line from the upper border of the ear canals to the lower border of the orbit of the eyes should be parallel to the floor and perpendicular to the vertical backboard. So this is called the Frankfurt plane. So you can see this in the previous picture. So this is called the Frankfurt plane. It should be parallel to the floor and perpendicular to the vertical board. So this is another picture showing how height is taken using a stadiometer. There should be no shoes or socks. Head should be held in the Frankfurt plane. Feet back and back of the head should be touching the foot plate or the back plate. This is the Harpenden stadiometer. Next is, so certain important things which you should remember in the height. So average birth length is 50 centimeter. By 6 months, it is 66 centimeter. By 1 year, it increases by 50%. So if the birth length is 50 centimeter, it is 75 centimeter by 1 year. And by 4 year, it doubles. That is 100 centimeter. By 12 year, it triples. So this much, if you remember, it is more than enough. Birth length is 50 centimeter, 1 year it is 75, 4 year it is 100 centimeter. And we also have each formula for calculating the height of a child. That is 6 into age in years plus 77. So this is the general formula to calculate the height. If you don't remember this, you can use the formula to calculate the height. So growth velocity is much more important. So from birth to 12 months, so velocity is the rate of increment during a particular period of time. So that is called velocity, growth velocity. So birth to 12 months, it is 24 centimeter per year. From 12 to 24 months, it is 10 centimeter per year. 24 to 36 months, it is 8 centimeter per year. In childhood, it is 6 centimeter per year. So this is the growth velocity, and this is also very important. So next is upper segment, lower segment ratio. So how do you calculate the upper segment, lower segment ratio? So the lower segment measurement is taken from the pubic symphysis till the floor. Then the upper segment is calculated by subtracting the lower segment from the whole height. So this is how you get the upper segment, lower segment ratio. And the most important thing to remember is by birth, 1.7 is to 1. It is the upper segment, lower segment ratio. By 3 years, it is 1.3 is to 1. After 7 years, it becomes 1 is to 1. Some book says after 9 years. Nelson says it is after 7 years. The upper segment, lower segment ratio is 1 is to 1. So this is important when we come across a short stature. So if there is any disproportionate or proportionate short stature, this gives a clue to diagnosis of certain diseases like hypothyroidism, syndromes, and then spondyloepiphyseal dysplasia, achondroplasia. So when there is a variation in the upper segment, lower segment length, it gives clues to certain diagnosis. So that is why this is important. So next is a head circumference. So what is the instrument used is non-stretchable measuring tape. That is very important. So how to measure the head circumference? First, place the measuring tape around the child's head so that the tape lies across the frontal bones. Three things are very important. It should be above the eyebrows in the supraorbital ridge, perpendicular to the long axis of the face, above the ears, and over the occipital prominence. So these are the three landmarks: above the eyebrows, above the ears, and over the occipital prominence at the back of the head. Tighten the tape so that it fits snugly around the head and compresses the hair and the underlying soft tissues. So this is how you should measure the head circumference. This is another picture showing how they are measuring the head circumference. So the at birth head circumference is 35 centimeter. So it increases at the rate of 2 centimeter per month in first 3 months, 1 centimeter per month in the next 3 months, and 0.5 centimeter per month in the next 6 months. So this much you can remember. If you know this, you can calculate the head circumference for any child at a given age. So first 3 months it is 2 centimeter, next 3 months it is 1 centimeter, next 6 months it is 0.5 centimeter per month. So next is chest circumference. So instrument used is non-stretchable measuring tape. So how do we measure the chest circumference? It is measured at the level of nipples, midway between inspiration and expiration. So this is how you measure the chest circumference. So one thing to remember in chest circumference is at birth, head circumference is more than the chest circumference. It both gets equals by 1 year of age. At 1 year of age, head circumference is equal to the chest circumference. After 1 year of age, chest circumference is more than the head circumference. So this much you should remember. So mid upper arm circumference, we measure mid upper arm circumference only for the children between 6 to 59 months of age, not more than that. So how to measure the mid upper arm circumference? Instrument used is again the same thing, non-stretchable measuring tape. So how the child should be: shoulder should be relaxed and the left arm should be held loosely by the side, and you should mark the bony prominence, acromion process of the scapula, here olecranon process of the ulna. So this is the bony prominence. Take the midpoint. At the midpoint, pull the two ends of the overlapping tape. Check that the tape fits snugly around the arm, but it should not compress the skin. So this is how you measure the mid upper arm circumference. So the another one is the Shakir tape. This is also asked in exams. So using this, it is nothing but a color coded tape. So it also used for measuring the mid upper arm circumference. Only thing is it is easy to measure. So you have 3 color zones. If it is a green zone, if the child's mid upper arm circumference falls in the green zone, then it is normal. That means the upper arm circumference is more than 13.5 centimeter. When it is between 12.5 to 13.5, it is borderline and it falls in the yellow zone. So red one is the danger one, which when the mid upper arm circumference falls less than 12.5 centimeter, that means wasting is present in the child. So this is a easy method to calculate. Next is skin fold thickness. Actually, it's not important, but when they ask in the exam, you should be able to say what is that. Harpent and calipers are used for measuring the skin fold thickness. It is also used to assess the malnutrition in the child. So here what we are assessing is skin and the underlying fat. Both are caught hold between that that calipers. So we measure the thickness. That's all. So body mass index, you should remember the formula. So how do you calculate BMI is weight in kg divided by height in meter square. And this is the this you should mention when you are examining a child of older age group. More than 6 years, you should mention the body mass index. Less than that, it is not necessary. Less than 6 years, usually you will mention about height, weight, head circumference. But more than older children, you should mention the body mass index. So these are the average growth parameters at birth. Weight is 3 kg, length is 50 centimeter, upper segment, lower segment ratio is 1.7:1, head circumference is 35, chest circumference is 33. So these are the growth parameters at birth. So now we are moving to growth charts. So how to plot in the growth chart, that I'll be telling now. For basic things you should note in the growth charts are, so age is plotted along the x-axis and measurements are in the y-axis. So we have two types of charts. One is percentile chart and the other one is Z-score chart. Both can be used. So we have separate charts for boys, which will be in blue color, and for girls it will be in pink color. So any charts, growth chart of weight, height, or head circumference, or BMI. So we have various different growth charts for different parameters. When the values are below the 3rd percentile or above 97th percentile, it is considered abnormal. Weight, height, for anything. So if it is 3rd percentile, it is less than -2 standard deviation. If it is above 97th percentile, it is more than +2 standard deviation. So values between these can be taken as normal. When the values are beyond this level, it is taken as abnormal. So these are the recent charts. These two are the combined WHO IFP growth charts used between 0 to 18 years, and the pink one is for girls and the blue one is for boys. So this one is the BMI chart. So here you have two lines like 23 adult equivalent and 27 adult equivalent. If the child's BMI is falling above this 23 adult equivalent, it is called overweight. When it is more than 27 adult equivalent, it is called obesity. And this is example for an Z-score chart. Here you have in standard deviations, -1, -2, -3, +1, +2, +3. So Z-score will represent in standard deviations, whereas percentile chart means you have 6 or 7 curves marking as 1 percentile, 3 percentile, so 99, 97. So you'll have different percentile curves. So how to plot, this is an example, how to plot height on a growth chart. Suppose we have an 8-year-old boy whose height is 115 centimeter. So what you should do is, first you should draw an imaginary line along the x-axis till you reach the 8 years. So down you can see the age in years. So move your pencil until 8 years. So then extend the imaginary line along the y-axis till the height of the child. So here we have 115 centimeters. So move up until the 115 centimeters. So you mark that point, and so this is how you check. So just when you have marked it, look at the centile, beyond which centile it is falling. So if it is less than 3rd centile, then it is abnormal. Or if it is falling less than -2 standard deviation, then that is abnormal. So how to calculate the target range for a child's height? So that can be calculated only from the parent's height. So that is called mid-parental height. So you should take the mother's height and father's height, maternal height and paternal height, whole divided by 2. If it is for a male child, you add 6.5 centimeters. If it is for a female child, you subtract that value by 6.5 centimeters. So that will be your mid-parental height. That should be the target height for the child. So this is how you calculate the mid-parental height. So there are certain terminologies which you should understand. So why this growth chart is very important. The significance of it is we should find out whether the child is in a good nutritional status or falling in underweight or overweight, or there is stunting, or there is chronic malnutrition. So for finding out these things, growth charts are very important, and also to assess the height, velocity. So these two are more important things. So for this, you should understand the certain parameters. Underweight is when the weight for age is less than -2 standard deviation of WHO child growth standard median. And stunting or short stature is when the height for age is less than -2 standard deviation of the WHO child growth standard median. Tall stature is when the height for age is more than +2 standard deviation of the WHO child growth standard median. Wasting is when the weight for height is less than -2 standard deviation. So underweight is when the weight for age less than -2 standard deviation. Wasting is when the weight for height less than -2 standard deviation. These two things you should remember. So height age is the age that corresponds to the child's height when plotted at the 50th centile on a growth chart. So that is the height age of the child. Weight age is the age that corresponds to the child's weight when plotted at the 50th centile on a growth chart. That is called weight age. Weight for age is different. So weight of the child divided by weight of the normal child of the same age into 100. So you will get the weight for age. Height for age is length or height of the child in centimeters divided by length or height of normal child of the same age into 100. That will give you the height for age. Weight for height is weight of the child divided by weight of normal child of the same height into 100 will give you the weight for height. So suppose if they're giving a child's weight, you should calculate the weight for age, and you can use either any of the classification. Here I have given a sample IAP classification method. So there will be 4 grades. So you should calculate the weight for, you should use this formula to calculate the weight for age, and you should apply it here. So you should see in which grade the child is falling under. Percentage of standard weight for age. So grade 1, grade 2, grade 3, grade 4, 4 grades are there. So you should calculate accordingly, and then you can write it in the exam. So this is how you find out which grade of malnutrition the child is falling in. So you can include it in the diagnosis. So this child falls under grade 1 of malnutrition according to that IAP classification. So thank you. Sir?
Thank you, ma'am.
Ma'am, thank you, ma'am.
Thank you so much.
Okay, sir.